My mic on. I think we'll go ahead and get started as it's just past 11 o'clock. Thank you all so much for joining us here today for our event, A New Approach to Leaving No One Behind. It's a great challenge for us at ODI as we've been doing so much work on No One Behind to come up with new titles for our events, but hopefully we've done it in a way that has successfully enticed a massive show of people to come and join us this morning. We've got about, last time I looked, up 227 people watching online as well, so hello to everyone watching. I'll introduce our speakers in a minute. We were hoping to have at least one of our guest speakers in the room with us, but that's not happened, so we are limiting the carbon footprint of this event as well by having three of our speakers joining us online. So we are going to be a little bit reliant on technology working for us, but that should be fine. Please, as ever, feel very free. In fact, we actively encourage you to tweet the event, hashtag Leave No One Behind. And let's get started. I'm not going to bother explaining or even introducing the concept of Leave No One Behind and why it's important. I'm going to assume that all of you are here because you've already bought into the importance of this as an issue. But I do think it's worth touching on the urgency of why we need action to start on Leave No One Behind as quickly as possible. We did some analysis last year at ODI that showed that if countries don't start delivering on Leave No One Behind actions and policies within the first 1,000 days of the SDGs, so that's September 2018, if you want to do the math, then it's going to be pretty much impossible to deliver on this commitment. And I think that's a pretty salutary warning. Time is really of the essence here. We are pushing on to being halfway through that 1,000-day period. So, again, this is to stress the urgency of this agenda. And this is why with the piece of research that we're launching today, we wanted to take this concept from the, it's been up here, the sort of slightly ephemeral, conceptual level of leaving no one behind, and we've wanted to get much more granular, to be very, very specific about what needs to be delivered at the national and, very importantly, the sub-national level across different sectors and across different, using different instruments. So we've we've deliberately made this work interdisciplinary. What are the data elements? What are the policy elements? What are the financing elements? And of course, what's the sort of enabling political environment that's going to allow this all to happen and mean that countries can start delivering on Leave No One Behind? So we're obviously looking at the work we've done on health today. I will also tell you, though, that we're launching, so that's the health report. I've got too many things on my knee. That's the health report we're launching today. We have done also a report on Leave No One Behind on roads in Kenya, so access to rural roads. And we're also publishing today a methodology because we'd like other people to be undertaking these forms of sort of Leave No One Behind diagnostics. So we've published our methodology for how we've done this work. And we've launched some interactive maps that we should be able to show you now. So you can, these will show you various maps looking at health, various health coverage, roads. You'll be able to, there'll be some laptops out around the lunchtime period, and I'd encourage you to have a play around and look at these. You'll be able to see work we've done on looking at, for instance, coverage of 8 different health indicators, looking at access to coverage. The roads map, for instance, will look at the distance of communities to the instance of communities that are 5 or 10 kilometres away from a rural or gravel paved roads, and also overlaying that with our Leave No One Behind and roads index. So is financing getting to where the need is? So I'll leave you to play around with those at lunchtime and have a little bit look more at them. Before we start, I would like to use my chair's privilege just to take a quick show of hands in the room. And if I ask a question, and this is exactly the kind of granular question that we've been asking with our research, if I ask the question, why is it you think that women in rural areas in developing countries are not getting access to healthcare, what would you say is the key impediment? Can you show me? Who would say it's the government lacking data? Can you put your hand up if you think it's data is the key impediment to women in rural areas not getting access to healthcare? Okay, that's around 0 for data. Who think it's an old-fashioned resource question? This is about government having a lack of resources. A couple of hands over there. Okay, not many. Who think it's about politics, and specifically local politics? You've had your hand up twice, sir, over there. Okay, more people. Who thinks it's all of the above? Okay, pretty much everyone. Okay, I will reveal with you the results. We had a Twitter poll that asked the same questions, and you'll see the answers that we had there actually very similar to the number of people in the room. Right, well, we're going to unpack all these questions in this session. Let me move next to introducing the speakers. If we could start with Maita Jamangani. Can we get Maita up? Can we make sure Maita's, so we can see and say hello? Right, she's the largest screen in the room. Maita is the National Director of the Gender and Sexual Diversity Network in Zimbabwe. She's a long-time grassroots activist on these issues, and she's also working at connecting civil society and policymakers and making sure that issues of poverty and inequality are visible, among marginalised people, are visible to those groups. So thank you very much for joining us, Maita. Can you say hello so we know we can hear you and you can hear us? Can we say hello? We'll say hello later. Okay. Next, we're joined by Isabella Maina, who is, I hope Isabella can hear and see us as well, head of the health sector monitoring and evaluation unit at the Ministry of Health in Kenya. Can you say hello?
They've got their microphones on mute.
They're all muted. Okay, we'll say hello to you later. That's okay, we'll say hello later. Hello, there we are. And then we have Mamadou Toure, who you can see there, who was going to be joining us in person and now can't. And he's the Poverty Research Director for the think tank Development Initiatives, and he's joining us from Nairobi this morning. And he's waving. Thank you, Mamadou.
Hi, everyone.
Hi there. Good, we've got a good line too. Let me start by coming to you, Maita. I think it's really helpful to start the conversation by grounding this in a reminder of why this issue is important at the national level and at the community level. And Maita is going to just give us a very quick reminder of why this is the case. We got her? Can you unmute? Okay, you need to unmute, Maita. Can we hear you? No. Okay, we'll come back to that. That's okay. We'll come back to that. Let me instead move to my colleague Olivia Tulloch, who I haven't yet introduced. So Olivia is a research fellow in our politics and governance programme and is also an expert on community health and community health systems. And Olivia, I'm going to start by asking you to briefly present your research, and then I'm going to ask you some questions on it.
We have the I think you've got a slide. Okay. By way of presenting our findings, I thought we could have a story, just to bring alive the realities of some of the people that we encountered in our research. And I'm going to use the story of a young lady called Grace. She's photographed in the middle of that picture with her baby and one of her female relatives. And her experience is not an unusual one for a rural Kenyan woman. And the types of barriers that she faced in accessing healthcare could equally be faced by a rural woman in another county of Kenya, or even in a rural part of Nepal, which is the other country where we undertook this research. So I'm going to focus on just one type of vulnerability today. There's no way we can cover them all. So that's of a poor rural woman. Now, knowing that that Grace is like many Kenyan women in her situation, we invited her to join us in a focus group discussion to try and find out what the issues were that she faced in accessing healthcare. So she and a lot of her friends and other community members came along and had a chat with us. She lives in a remote village looking rather like the one you see in the photograph on the left-hand side. And that village has no road leading to it, and it is far from the nearest town. It is a Maasai community, so she is of an ethnic minority. She has quite a harsh life, but not an unpleasant one. You know, we were looking at people who struggled financially and had a low cash economy, but had plenty of food, plenty of goats. They had meat, milk. They drank blood as one of their sources of protein. It might sound surprising to some of us, but that's one of the drinks of choice. Now, Grace has 4 children. She's 26 years old-ish. She's not quite sure. She has no ID. And without that ID, she's also not able to access many of the services that other people would be entitled to access. She's probably going to have quite a lot more children too, because she has no birth control and is a little bit confused by it because nobody's ever really explained it to her. Now, there's no road to the place where Grace could go to give birth to her children. She would need to walk there. And one of the people that we interviewed said, you just need to look at the road network. Are you able to walk 25 kilometres to the health centre, or do you slaughter a goat and ask a witch doctor to take away the bad spirits? And that was a typical sort of experience that we heard about when listening to women's experiences of what they felt about going to receive healthcare services. Now, politicians know about this and they try to do things about it. So we heard that very close to where Grace lives is a new dispensary. It was built a couple of years ago. There's a picture of it there in the far distance, right in the middle of nowhere. But unfortunately, nobody has ever gone to that facility to work there. There are no drugs, there's no equipment. It has never been opened. So the place where she should be going to get healthcare is not available. And the place that she could go to get healthcare looks something like this. This is one of the health centres that we visited. There is a very committed nurse there on the left saying, look at where I have to work. There's not even a fence to keep out the stray dogs. And she showed us around her health facility and said, here on the right-hand side is our labour ward. Now you can see in that labour ward there's a large pile of mosquito nets which were kindly donated by the American government, and all sorts of other bits of equipment, but certainly nothing that you would need in order to give birth. So you can see why Grace might decide that the best option for her is to give birth at home. So that's just a quick snapshot to introduce the sorts of experiences that women in a remote part of Kenya face.
Great. Can you, I mean, famously, whenever we talk about leave no one behind issues, the number one problem that comes up time and time again is data availability, and particularly availability of disaggregated data, disaggregated to the appropriate level that we need to be able to do any kind of analysis. Can you talk us through the kind of data, where you found the data, so the kind of data that you were using for the study, and also just some of the key findings in terms of who was being left behind in terms of access to health?
So we looked at 2 main types of data. That was financial data and also health coverage data. So we looked at the demographic health survey and also a measure called the Composite Coverage Index, which is a World Health Organization measure to look at some of the services that people are able to access. So it's a sort of proxy measure of health service coverage, and we were using it like a proxy for universal health coverage. So we looked at those 2 sources, those 2 types of data. And one of the things that we found was that, that the data isn't collected really frequently enough for us to have an accurate picture of what things are like right now, but also that the data that is being collected is not giving us necessarily a full picture. So we know that where a lot of exclusion lies, but what we weren't able to identify is some of the pockets of exclusion. So we know that some counties have very poor health service coverage, but others have quite good coverage. But within the county that might have good health service coverage, there might be real pockets of neglect, which just are not adequately represented in the data. That's one of the issues we found with the sort of health data. With the financial side, we were able to see that there are some very progressive policies in place to allocate financial resources to the people that need it most. But quite often those are not quite getting to the people that need them, because we don't know exactly where the people are. And there were some sort of political machinations that meant that it wasn't always getting through.
Okay, perhaps we can come back to the political machinations question later, because that's fascinating. But can you talk, Kenya now, Kenya already had a pre-existing commitment around universal health coverage. Now, of course, all countries have signed up to UHC as a commitment as part of the SDGs. Can you talk us through some of the kind of trade-offs that you had found in your research that were having to be carried out, whatever you do with a trade-off, to be able to get as far towards UHC as they're getting?
It's a really important question, because we do see that in both of the countries that we looked at, there are very clear commitments on paper and in things that are being enacted, in policies within the constitutions and various other frameworks which show real recognition to a commitment to vulnerable people who are not getting the services that they need. But these are the people who are most difficult to reach. If we look at vulnerable communities, they live far away from health centres. It's very expensive to get health services to the places where they are, and the sorts of services that they need, just primary health care, are expensive to deliver in those places. And so we heard from from a lot of our respondents, particularly in the second country we went to, which was Nepal, that the low-hanging fruit has been picked. So all of the quick, easy gains in health service delivery in terms of primary healthcare have been achieved in a really impressive way in quite a short time. There have been great progress towards let's say, the Millennium Development Goals. But the Sustainable Development Goals are all about getting to those people who are not easy to access. And so it's about having to choose to throw money at getting services to those sorts of people against other types of health services for other people. And that was a real issue that particularly people in the NGO sector said governments are going to struggle to justify this. It's a lot of money to benefit a small number of people remaining.
And just to be clear then, who had they chosen to prioritise? I mean, we'll come to Isabella in the Ministry of Health later to get her response, but yeah, who is getting the benefit and who isn't?
Well, certainly that there's suggestion that those people are being prioritised, but is it enough? I think that's the question. Okay. Is it really going far enough? So it's a question of adequacy
of resources as well. Yeah. And if I could, going back to our Twitter poll and our show of hands, if I had to ask you what was the key bottleneck? I mean, you've mentioned some of them sort of in quite general terms, but if you had to identify one key bottleneck, what would that be?
Oh, goodness. Well, I would say probably adequacy of resources. I'm going to answer them all in one again, but I think I would say resources, because if you don't have enough staff, if you can't pay for the staff to be delivering services in those places, then it's a non-starter. So yeah.
Okay, great. We'll come back to more about the study.
I don't like answering that question at all. Yeah. It's a tough one.
We can come back to it later, because I'm sure there'll be more questions about the study. I'd like to turn now to bring in Isabella. From the Ministry of Health. Isabella, do you recognise that? We've talked about the commitments that you have at the policy level to UHC, and actually that there's actually, compared to plenty of other countries, a relatively, would you agree with that, a sort of relatively progressive financial formula. So why would you say it's not happening? Do you recognise the bottlenecks that Olivia's just identified, or have we missed something? What's the reality that you're having to live with?
Okay, thank you, Olivia, for that brief. Yes, as you said, there's progressive financial formula for allocation of resources, and this is based on the Constitution of Kenya. There's equity in allocation of resources because the Constitution says at least 15% of the national budget must go to the counties. And then for the counties that are marginalized, there's equalization fund to make them come up to the level of the others, so to speak. And if we come close to health, there's a lot that has happened in terms of allocation to the counties. We've seen progressive increase in resources. But as she has rightly put it, we are still yet to get there. But there are attempts and strategies that have been put in place, especially in health services. We now have, in terms of removing financial barriers to access to services, especially for the poor, the government has removed user fees at the primary care facilities. And these are facilities that, by and large, utilized by the minorities or the people in the rural areas. Mm-hmm. The other thing that has happened is removal of maternity fee, so that deliveries or maternity services in public health facilities are free. And the government is also working towards ensuring that these services are also extended to non-governmental facilities and also to private facilities. And also revamping our national insurance fund, the NHIF, the National Health Insurance Fund, to make sure that they are covering not just the formal sector, because initially they were covering the formal sector, but now extending to cover the informal sector, and also extending the package from inpatient cover to cover also the outpatient. And that would mean, because the primary care facilities where the minorities and marginalized groups usually access care only offer outpatient services. So that would mean that previously, when NHIF was only covering the inpatient services, such groups were not able to reach such financial cover. So there are lots of efforts, but I would say that finances are not enough. There are disparities as much as the allocation is a minimum of 15% to each counties. The counties are now entities, they are autonomous entities, and therefore they also have their own formula of allocating resources. So you'll still find disparities within counties. Mm. Yeah, as much as they receive a minimum of 15% from the national government, with the counties have the decision, they make the decision as to how much they allocate to health. So if you look across the 47 counties, you'll find disparities. So that there are some counties in the last 4 years that have progressed in terms of financial allocation. There are some that maybe are allocating the same amount that the national government was allocating pre-devolution. There are others that maybe the rate of increase has been so slow. So there are all these multiple factors that are barriers.
Great.
Thank you. That's in terms of finances, but of course there are many other bottlenecks.
Okay, thank you. And again, we may come back to some of those other bottlenecks later as well. I wanted to bring in Mamadou Touré here. I mean, first of all, were you surprised by our findings and did we miss anything? But and I can ask Mamadou that because he was one of the reviewers of the study, so it's a fair question. But secondly, I want to go back to the data issue and ask you about citizen-generated data or other forms of unofficial data. What's the status of that kind of data in Kenya at the moment? Is it in a state where it can be used by policymakers, by researchers, by civil society to identify marginalised group and track progress, or is it not there yet?
Thank you, Liz. I think what I liked about this study is, first of all, the data source that was used, which is DHS data. It's perhaps the best we can use for this sort of study. I know some of my colleagues would prefer a sort of joined up DHS mix data, which would still give more information, but mix would mainly focus on women and children and these are adequately covered in the DHS data. I also like the reference to a framework, the CCI framework, which really is a good cover of health issues as far as a poverty perspective is concerned. Mm-hmm. In Kenya at the moment, there is a lot of hype on citizen-generated data. And one of the qualities of citizen-generated data is that it helps to hold decision makers to account. It is not as technical and malleable as official data, but it does bring out people's perspectives, particularly in a situation where, for instance, in Kenya, they do a lot of service delivery surveys. These delivery surveys can definitely be a tool for monitoring whether health outcomes or health inputs are being sufficient to meet the needs of people, and whether the outcomes are up to scratch as far as inputs are concerned. Yes, I would say citizen-generated data has a lot of future in this type of work, and I think it is suitable for holding decision makers to account. Where it is failing at the moment is its compatibility with official data, so that it is easily taken on board on national statistical platforms. And I think that's one big challenge that the Leave No One Behind agenda puts before us.
Yeah. Okay. Okay, that's very, very interesting perspective to hear, and interesting, I think, particularly from Kenya, because along with other countries like, for instance, the Philippines, I think it's a place where citizen-generated data is relatively advanced. So it's interesting to hear that perspective. Maita, I'm going to bring you in now. I'm sorry we couldn't hear you earlier. Maybe you can start your response to my question by giving us your story on why it's important that we're asking these questions. But I'd also like to hear from you whether the bottlenecks and the challenges in terms of marginalised groups getting access to healthcare that we've heard about today, does this resonate for you? Is this similar at community level in Zimbabwe? Are you facing similar challenges? Are there similar bottlenecks? Is it something else? I think it's interesting for us to start to get a sense of how sort of scalable these lessons are, how much these are shared difficulties and issues from elsewhere, other countries in the region.
Thank you very much, Elizabeth. Can you hear me now?
I can hear you, yeah.
Right. The Leave No One Behind discussion that we are having today is very, very important and very close to my heart. First, I will start with the Constitution of Zimbabwe, which states in Chapter 76, Section 1, that every citizen of Zimbabwe has the right to access basic healthcare service, but that is not for everyone. LGBT persons are considered illegal. Dogs, pigs, insects, but certainly not human. Let me give you a personal experience. Last year, my partner and I decided to go for a voluntary HIV testing and counseling center after we decided that we wanted to take our relationship to the next level. When we got there, we went through the registration process, which involves providing pseudonyms. And we waited there, and finally, when we got to the testing and counseling room, we met a motherly figure, and she described to us the procedure, including the issues of confidentiality, transparency, and honesty for us to get the right care and support. So we decided it was okay to open up and be transparent and tell her about the nature of our same-sex relationship and sexual history. But, well, it turned out differently. She was unforgiving. She told us we could not continue with the service. She told us because it was against her ethics, against her nature, against the laws of Zimbabwe. She told us she was going to call the authorities immediately. She banged the door and she left. We could not wait. we ran for our lives. We knew we could face a jail term and we're not going to get tested, and we're not even going to access any healthcare service, even if the Constitution says we have the right to healthcare. We are in desperate need of global solidarity to put pressure on our African governments so that they can be accountable for LGBT persons, so that no one is left behind. Thank you.
Can I just press you on why? So I mean, the thing that your story very starkly sets out for us is that there's a normative issue here, that it's sort of culturally a discrimination that you as somebody coming from a marginalised group, that you are living on a day-to-day basis. Are there other sort of structural issues that you've identified? Are there other reasons that you've identified in the communities that you work with why people are not getting access to healthcare? Is it just manifesting itself at the cultural level, and political, social level, which means then presumably that financing isn't coming, that there isn't the sort of political will to deliver access to healthcare into other marginalised, into rural community areas? Are there other reasons as well?
The problem, Elizabeth, I think that the issue of data is very important, because those that are making decisions at a policy level do not have data that explains and show them the burden and the inequalities and injustice that we face as LGBTI people, because we are considered as illegal and therefore non-existent.
Thanks very much. Okay, so I think that discussion has opened up really quite a lot of issues that have interestingly spanned the kind of areas that our conceptual framework for the study started looking at. So there is the data issue, there are cultural issues, political issues, and then financing issues as well.